Thank you, Dan. These are my disclosures. And so I'm going to talk about the various aspects of the expense of using the robot in a training program. And I think I'm going to touch on a couple topics that you may not have thought about that I think are expensive. Obviously, I'm going to talk about dollars and time, increased amount of time that it can directly translate into costs, but also it's taking a toll on training. In our program it has. And then there's a little bit of an issue about safety, not nearly as much, but maybe in the future. So a fully loaded robot that our institution bought with all the bells and whistles on it, it's not $2 million, it's $2.8 million. And the data I'm going to give you are pretty much UVA data that we got from our administrators. So if you think about that, if you're an associate professor, that's 50th percentile salary for over 11 years that you would be working to pay for a robot. It's kind of an interesting way to look at it. And oh, by the way, the service contract is $167,000 a year, and all the parts, the disposable parts for the robot, are made by Intuitive, and we know they have a lot of competition in the market, so are obviously very competitively priced. Anyway, you've seen data from the other talks, and it's generally accepted that it's at least $3,500, $33,000 to $6,000. But this Healthline News article last year quoted about a $3,500 difference in the cost of the operation. And so I'm asking you, if we talk about healthcare, if you pick up the New York Times, you pick up any kind of an article about healthcare, and what's the problem with healthcare? What's cost? And what is the biggest problem in the U.S., and that's healthcare costs. It's now 17.1% of our GDP, expected to go up to 19% in another 2 years. And it's the single biggest issue that we're facing. I mean, that's the biggest problem we have. And we as surgeons don't have a whole lot of handle on the cost anymore. Our administrators hire more administrators, the costs go up, we have to pay insurance company executives and all these other folks that have gotten involved in splitting up the healthcare dollar. But there are a few things that we can control. And obviously quality is one. So we obviously definitely want to make sure that we render the best possible quality care for our patients. And if the quality is the same for two different ways to do a procedure, but one is less expensive, I do think we have a moral obligation to address the problem of cost and think about it in our practice. And so I think that one of the things we can do is to be responsible and choose the less expensive option in terms of providing an operation. So I ask you, would you pay $7 for a gallon of gas? Same gas, burns the same. $15 for a case of bottled water, or $50 for a movie ticket when down the street you can get one for $18? Of course you wouldn't. And how many people are going to run into the store where this sign is on the front? I mean, it's just not going to happen. Where else do we intentionally choose an option that's a lot more expensive, that doesn't yield any benefit? So now, the next couple slides include some data that is in peer review, so I can't give you like all the data, but I can give you a little bit of it, and this is for our institution looking at cholecystectomies done laparoscopically versus robotically. The difference in time between those cases was 30 minutes. The difference for inguinal hernias was 71 minutes, and the difference for ventral hernias was 96 minutes. All highly significantly different. And in our institution, they charge $68 a minute for OR time. So just the time difference in terms of what's going to appear on the patient's bill runs between $2,000 and $6,500 additional cost just for the time to do the operation. And that doesn't include the fact that when they set up these procedures, if you set up in a cholecystectomy, it's a level 1 procedure, it has like a $900 setup charge. If you set up a level 2, and I think the robot's even level 3, but even just going up one level jumps it up another $1,000. So you've got to add a lot of cost here. That's not just, I think the $3,500 is an underestimate. At least in our institution, it certainly is, based on our current practice. Now, the thing that I do want to emphasize today that I think a lot of people don't think about and has come to light recently in our institution is the cost of the robot on junior resident surgical training. Here are some graphs, and I've had to take off the y-axis, but I can keep the years up. And you can see I don't know that, I'm sorry that blue line doesn't show up too well on the bottom, but here it is coming up here. Here's when robotic surgery started in our institution doing general surgery cases. And so you can see the increasing number of robotic general surgery cases done. Simultaneously, you can see the decreasing number of laparoscopic general surgery cases done for the same period of time. Breaking those down by procedure, in the upper left-hand corner is cholecystectomy. You can see the dropping red line. Inguinal hernia, you can see the crossing lines. And ventral hernia has stayed up a bit despite the rising robotic cases. So basically we are doing less general surgery laparoscopic cases. Now, who generally in our institution, the residents do the cases. So guess what? Now that these cases are being done on the robot, the junior residents aren't doing the cases. And for over 200 laparoscopic robotic general cases done in the last 2 years in our training institution, only 20% of the time a resident actually sat at the console. And of those cases, 90% of the time that resident was a PGY 4 or 5. So basically we've taken those entire block of cases and the junior residents don't do them anymore. I mean, that to me is, as a program director, as an educator, that is a big expense. And I don't think anybody's really thought about that. And check out your own institution, because I think if it's happening at our place, it's probably happening at your place too. So finally, the safety issue. Anyway, you've heard a little bit about the lawyers, cases, setup, and so forth. You know, I think this is just something on effectiveness, and I have to quote the obvious authority on this, and that's the SAGES Surgery Consensus Group, and they say there's no efficacy for cholecystectomy, and for solid organ surgery, maybe even less. So, and Dan, you know about that because you were senior author on that. So the ERCI Institute is an institute, a nonprofit institute that synthesizes and gives information, and it's basically analyzed over 4,000 studies on robotic surgery. Their conclusions are that the evidence isn't strong enough to determine whether robotic surgery is any better than minimally invasive surgery, and they also list robotic surgery as one of their top 10 healthcare hazards for last year. So I think there is a safety issue that's a little bit under the surface that hasn't really been fully investigated. So finally, I pose to you, I think this is a moral dilemma. I think that we do have the responsibility to do the right thing and declare the robot as too expensive to routinely use in general surgery training. It's too damaging to training based on current trends. But I have an idea. I think there may be a good use for the robot. And you know, as I was planning this talk and thought about the weather here in Boston, what it might be like in March, you know, I thought about getting Dr. Finelli and Dr. Truss to use the robot for a potentially important use during the meeting, and that would be in case we got snowed in. There they are. They're practicing up there. And this would be a good use for the robot, I think. So, thank you.
Well, taking the opposing view will be Dmitry Olenikov from Omaha, Nebraska, who will be arguing that the robot is critical and as such is not too expensive for use in a training program. Dr. Olenikov, welcome.
Thank you very much. Welcome, everybody. Let's see. Can we go ahead and tee up my presentation, please? Well, that's concerning. There we go. The robot is too expensive to use as a training tool, and I would disagree with that. Here are my disclosures.
It just takes a minute to just give it a second.
Any minute now. I'm a founder and shareholder of a company called Virtual Incision Corporation. That company is a startup, and we are building small, inexpensive micro robots that are purpose-built. And I promise you, while there's no financial problem with this talk, this, I think, is the future of robotics. However, we're not selling anything yet. We're still in the lab. So, all residents training is expensive. Training residents costs money, and the federal government gives us money to train residents because we all understand that those residents we train today are going to be our physicians tomorrow. The robot itself is definitely more expensive. It's more expensive because it's a monopoly, and Intuitive Surgical is not competitively pricing itself because it has no competition to price against. Robotic cases cost, on average, about $3,000 more for a VATS, for instance, owing to high robotic-specific supply depreciation costs. When there's amortization of cost of the robot itself, that number goes even higher to $3,200, and we've seen these numbers. I won't belabor the point too much. For endometrial cancer, for instance, the surgical procedure cost for robotic-assisted surgery, this is in pounds, European numbers, about 7,000 pounds compared to 2,700 for conventional laparoscopic surgery. Now let me just stop and say, the colleagues that perform endometrial cancer and hysterectomy at my institution are gynecology oncologists, and they can't do anything, probably not even tie their shoes without the robot. So ask yourself, what's the cost of doing this operation open? So as we move forward, we have to understand that the robot is an enabling technology for urologists who can't do their operation without the robot, and therefore your urologic residents need to be trained in the system. Gynecologists who cannot do a number of their operations without the robot. And in general surgery and in thoracic surgery, resident involvement is imperative for training. And if we're going to be using robots in areas where robots do make sense, then it's important to have robots as part of the training curriculum. Cost today higher, yes, but tomorrow, especially with new computer-aided surgical technologies, maybe even cheaper and better. As you see the data here, the conversion rates between open and robotic surgery are fairly similar. And so from an efficacy standpoint, the robot is probably just as safe as standard laparoscopy. In fact, there's some data to suggest that for colon surgery and deep pelvic surgery, the robots are a little better at the conversion factor than laparoscopy because of the difficulty working in the deep pelvis. A training protocol can enable residents to perform robotic surgery. I agree with Dr. Shermer that it is a crying shame that his junior faculty are not letting his residents get on the robot. I think they ought to. I think the junior faculty should feel comfortable doing certain things themselves as they get up on the learning curve, but they also need to be able to allow the residents to do some work as well. Residents using robots were able to successfully complete a robotic laparoscopic gastric band as primary surgeon after the median of 8 operations. No residents was able to had a problem completing that task as a primary surgeon. So, and this is data out of Hashimoto. So basically, you can get the residents on the robot. You can't let them do pieces of the operation until they can do the whole thing. And if you have any questions about that, look at the experience in urology and look at the experience in gynecology. Maybe to a fault, since they can't do anything else without the robot. Not teaching residents to use the robot will result in surgeons incapable of using advanced technology, including robotics. And that's an important problem, maybe not for this particular system because it's expensive, but for systems of the future. At some point, you have to introduce your residents to technology, and at some point, those residents have to become comfortable with the ability to use technology in a fairly difficult and complex setting, such as the operating room. Performance on tasks using conventional instruments did not correlate with performance using a robotic system. The residents who trained with conventional instrumentation did not perform significantly better on the robot exercise than those who trained with the robot first. What that suggests, basically, is you have to expose them to the robot, because if you just give them laparoscopic training, they still lack certain skill sets that you have to teach them on the robot. Although, granted, that skill set is less once you have laparoscopic skills. Increased operative times with resident involvement will improve with resident experience. We know, and we've seen publications where we understand that trainees take longer to perform operations. But there's a value, there's a societal value, because those trainees one day will become the caretakers of society. Significant learning was demonstrated by trainees in docking time, procedure time, duration of docking, and the trainees demonstrated a significant decrease in duration of procedure, meaning they learned quickly and effectively. Again, one has to have a curriculum with simulation as part of it to allow those residents to get up to speed faster so that training costs are decreased as much as possible. Robotic surgery is expensive now, you betcha, but that will decrease with time. It will decrease with time because of competition. It will decrease with time because the current system was designed many, many years ago for the tasks that it's not doing today. It was designed to do cardiac surgery as part of a remote surgical capability for the United States Department of Defense. A little known fact. Some of the early startup costs for getting the robot up and running were paid by your tax dollars. Say that to the intuitive folks. Finally, a single institution series has demonstrated lower supply costs with robot single-site cholecystectomy. A total of 458 cases, including 177 robotic cholecystectomy single sites, were compared to non-emergent admitted cases, including cost of analysis, and 46 of those cases versus 175 laparoscopic. Costs were less with the robotic unit if you just looked at supplies alone. Now, of course, we know that there are a lot more other costs involved, but the point is, if you can shave time, and if the robot supplies are less expensive, then all of a sudden, the actual finances begin to work. They're not working today, but I hope they'll work tomorrow. With that, I want to tell you that the residents are indeed our future, and we have to treat them well. I wish somebody could just cue the music now. Thank you.